Hi and welcome. So today we are going to look at Glasgow Coma scale, which has three main components. We have the eye opening, the verbal response, and the motor response. And I also have a simple mnemonic to make you understand this very easily. Now, when we look at the image on our right, this is a patient with head injury from road traffic accident. Now, from a simple inspection, we can only assess the amount of blood loss and areas of injury, but we cannot determine the depth as well as the severity of injury. And also, if there is any neurological involvement, we cannot determine that. And so, this is when the Glasgow Coma scale becomes relevant. And it is a neurological scale which shows an objective way of recording the depth and duration of coma and impaired consciousness in a patient. Now, this scale helps us to assess the impact of a wide variety of conditions such as acute brain injury due to traumatic as well as vascular injuries or even to infections, sometimes metabolic disorders such as hepatic or renal failures, or even hypoglycemia and diabetic ketoacidosis. Now, like I stated before, there are three main components of this scale. We have the eye opening, then we also have the verbal response, then we have the motor response. Now, the minimum score that a patient can get from eye opening is 1 and the maximum score is 4. The minimum score from verbal response is 1 and the maximum is 5. And the minimum score from motor response is 1 and the maximum is 6. And so the overall minimum score that a patient can get from these scores is 3, which indicates deep unconsciousness and also has a worst prognosis. And the overall maximum score that a patient can get is 15, which indicates the best prognosis. Now, a score of 8 or above has a good chance of recovery, and a score between 3 and 5 is potentially fatal, especially if it is accompanied by fixed pupils or absence of oculovestibular responses in these patients. Now, the first component of the scale is the eye opening, and the mnemonic with the eye opening is eye opens spontaneously to sound, to pain, but no response. What I want you to focus over here is spontaneously, sound, pain, no response. And so if the patient opens the eye without you asking the patient to open the eye and even blinks the eye, you score the patient 4. If the patient opens the eye only when you make a verbal stimuli, only when you talk to the patient, only when you give a command to the patient. For instance, can you please open your eyes? Then the patient opens the eyes. You score the patient 3. Now, if the patient only opens the eye to pain when you apply a painful stimulus to part of the body, but not to the face, then you have to score the patient 2. However, if the patient does not respond to any stimulus at all, the patient does not open the eye to any stimulus at all, you score the patient 1. So this is what I need you to take from this slide. Now, with the verbal response, I intentionally spelled it verbal for you to know that verbal response has 5 main components. And so the mnemonic that comes with verbal response is that orient confused people in appropriate words, not incoherent words, but no response. Over here, I need you to focus on orient, confused, inappropriate words, incoherent words, and no response. And so if the patient, talks to you, communicates with you spontaneously, then we say the patient is oriented. You ask the patient, what says the time? He says, it's 5 p.m. Where are you? He says, I'm in the hospital. It means the patient is oriented. So you score the patient 5. But if you talk to the patient and the patient sounds confused in his or her, answering that he is giving you, for example, where are you? The patient says, I'm here. It tells you the patient is confused, and so you score the patient 4. Now, if the patient makes inappropriate words that you don't understand, you score the patient 3. And if the patient makes, incomprehensible or incoherent words which no one understands, you score the patient 2. And if the patient makes no sound at all, if the patient does not communicate in any way, either to any stimulus that you apply, you score the patient 1. Now, when we look at the motor response, the mnemonic for the motor response is obey local people with pain. Don't flex or extend limbs, but no response. Here also, I intentionally spelled motor with an R for you to know that motor response has 6 main components. So I need you to focus on obey, local, with pain, flex, extend limbs, and no response. And so if the patient, does not, or you talk to the patient and the patient responds to you spontaneously or obeys whatever you ask him to do. For example, can you please raise your legs? Then the patient raises the leg. It tells you the patient has obeyed your command, and so you score the patient 6. Now, if the patient does not obey your command immediately, but you apply some, stimulus to the patient, and the patient makes purposeful movements because you applied some stimulus, it means the patient has localized to the pain, and so you score the patient 5. But if the patient withdraws to the painful stimulus that you have applied, you score the patient 4. And if the patient flexes the limbs abnormally, we call it decorticate posturing, you score the patient 3. But if the patient extends the limbs abnormally, which we call decerebrate posturing, you score the patient 2. Now, if the patient does not respond at all to any of the stimulus that you apply, you score the patient 1. And so this is an example of a decorticate posturing. As you can see, the patient has flexed the limbs. You can see the arms flexed to the chest and the legs are rotated inwards. This is decorticate. And this is a decerebrate posturing. And so you can see that the patient has extended, the head, as well as the limbs are on the sides and the legs are also pointing inwards. This is an example of decerebrate posturing. Now, all put together, if the patient opens the eyes spontaneously, score the patient 4. If the patient only opens the eyes when you talk to the patient or you make a sound, you score the patient 3. And if the patient only opens the eyes to a painful stimulus, you score the patient 2. If the patient doesn't open the eye at all, you score the patient 1. Now, if the patient responds or the patient talks to you without you even making any, stimulus, it means the patient is oriented. You score the patient 5. If the patient talks but sounds confused, you score the patient 4. And if the patient makes inappropriate words, he's given 3. And if there is incoherent or incomprehensible words, you score the patient 2. And if there is no response, if there is no verbal communication, you score the patient 1. Now, if the patient obeys your command, can you please raise your leg or raise your hand? The patient lifts the leg or hand. You score the patient 6. It means the patient has obeyed your command. If the patient makes purposeful movement to a stimulus that you applied, it means the patient has localized to pain. You score the patient 5. And if the patient withdraws to the painful stimulus, you score the patient 4. And if there is abnormal flexing, as in decorticate posturing, you score the patient 2. And if there is abnormal extension of the limbs, you score the patient 2. Then if there is abnormal or if there is no response at all to any stimulus that you apply, you score the patient 1. Now, analyzing the individual components as well as the sum of the scores are very important. And so we express the score in the form of Glasgow Coma Scale 9. In this case, it can mean that the patient had an eye opening of 2, verbal response of 4, and motor response of 3. And the time that we made this assessment was at 10 o'clock. Now we need to indicate the time because it will help us to know whether the patient is improving with time or is deteriorating over the time. Another important thing I need you to note over here is that if the patient has a score of 8, 8 could mean that the patient had an eye opening of 2, verbal response of 2, and motor response of 4. This same score of 8 can also mean that the patient had an eye opening of 1, verbal response of 1, and motor response of 6. And this will give us different implications for the severity of the patient's condition. And so it is important that we know the individual components of the scale so that we tailor our interventions towards the needs of the patient based on the score that we are having. Now, a score of 3 to 8 is considered that the patient is in coma, and such patients should be intubated to secure the airway. Now, another thing we need to know is that most of the time or sometimes endotracheal intubation and facial as well as eye swelling makes it difficult for us to assess the verbal response and also the eye opening response. And so in such a case, we write the score by writing 1 with a modifier. This is what I mean. For example, we may have I, which is 1C, where C means the eyes are closed, or verbal, where we write 1T, where T is indicating that there is a tube in situ. Now, often we leave out the 1, and so the scale is recorded as EC or VT, where EC means eyes are closed and VT means there is a tube in situ, and so verbal response cannot be solicited. Now, this is an example so that if the patient's eyes are closed because of severe swelling of the eye or facial swelling, and if there is an endotracheal tube in situ, we just write EC, VT, and when we assess and we get a motor response of 6, then it means EC, VT, M6 is equal to 6 at 12 o'clock, which is the time that we made this assessment. Now, based on this, we classify head injury into severe head injury, moderate head injury, as well as mild head injury. A severe head injury has a Glasgow Coma scale of 8 or less, and a moderate head injury has a Glasgow Coma scale of between 9 and 12, and a mild head injury has a Glasgow Coma scale of between 13 to 15. Now, a mild brain injury can result in temporary or permanent neurological symptoms, and neuroimaging tests such as CT scan or even MRI may or may not even show evidence of any damage. Whilst a moderate and severe brain injury often results in a long-term impairment in cognition such as thinking skills, physical skills, as well as emotional and behavioral functioning. Now, knowing the trends of the charts is very, very important. This is because it helps you, the doctor, to know whether the patient is improving or deteriorating with time. For instance, when we look at the eye opening, we realize that initially the patient was having no response. However, with continuous management, he started to improve and eventually he could open the eyes spontaneously. In verbal response, we can see that the patient during our evaluation was making incomprehensible, sounds. With time, the patient started making inappropriate words, meaning the patient started improving. But the patient stayed at inappropriate words throughout, the time, and so this tells us that there is something going wrong with the patient. Similarly, when we look at the motor response, what we find is that the patient could localize to pain initially, but unfortunately, the trend shows that there is a deterioration in the patient's condition, and this must draw our attention to the fact that something seriously is happening to these patients. And so, such deterioration should trigger urgent medical review in order to identify any remediable factors that have contributed to these changes. Now, this assessment may include performing cranial imaging, including CT scanning, to identify problems such as hematomas, contusions, or even brain swellings. Now, there are some limitations when it comes to using this Glasgow Coma scale. For instance, factors such as the use of drugs, also alcohol intoxication, and also if the patient is in shock or the patient has a low blood oxygenation level. All of these come together to alter the consciousness level of the patient, and so already the patient is having altered consciousness, and so we are unable to differentiate whether the patient is actually unconscious due to the head injury or the patient is unconscious due to the use of drugs or alcohol intoxication, or if the patient is in shock. Another key limitation is children. In children, we are unable to use the adult Glasgow Coma scale for them due to obvious reasons that they are children, and so they may not be able to follow certain commands. And so, in children, there is the pediatric Glasgow Coma scale, which is purposely used in children, especially those who are too young to have reliable language skill. This is just a modification of the adult skill, and so it still has components such as the eye opening, the verbal response, and the motor response. And so, if the child opens the eyes spontaneously without you asking the child to open the eyes, you score the child 4. But if eyes are opened only to voices, then you score the child 3. And if the child opens the eyes only when you apply some pressure, for example, to the chest or to some part of the body, you score the child 2. And if the child does not open the eyes at all, even to all the pressure and the voice that you make, you score the child 1. Now, with the verbal response, if the child smiles at you or interacts with you, and also if the child is able to follow objects that you move around, it tells you that the child is oriented, and so you score the child 5. If the child cries but is consolable, you score the child 4. But if the child cries inconsistently and is inconsolable, you have to score the child 3. And if the child remains inconsolable and also agitated, you score the child 2. And if there is no verbal response at all, you score the child 1. Now, with the motor response, if the child obeys your command, you ask the child, "Can you give me a hug? Can you give me a hand? Or can you hold my hand?" And the child obeys and gives you his or her hand, you score the child 6. But if the child localizes to the pain that you apply or the pressure that you apply to parts of the body before the child respond, then you say you give the child 5. And if the child withdraws to a painful stimulus that you are applying, you score 4. And if the child makes abnormal flexing, as in decorticate posturing, then you score 3. And if the child extends the limbs abnormally, as in decerebrate posturing, you also score the child 2. And if there is no motor response at all, you score the child 1. Now, uh, based on this, we can also classify head injury in the pediatric patient, and we use the same scoring as in the adult. And so, 8, a Glasgow Coma score of 8 or less reflects the most severe head injury. A score of 9 to 12 reflects moderate head injury, and a score of 13 to 15 indicates a mild brain injury in the pediatric patient. Also, as in adults, head injury, moderate and severe head injuries often result in significant, long-term impairment as compared to the mild head injuries. So basically, these are all that I have for you, and thank you very much for your attention. Bye bye.